Okay, I'm talking today about how I do it for distal carotid exposure. I have no financial disclosures. I am a co-director of the APEX Vascular Surgery course in St. Louis. So the distal carotid exposure is often mentioned. It's a favorite question for oral boards, and there are some important anatomic variants really that I recommend we go over and talk about. Is this becoming rarer in the era of transcarotid artery revascularization? Possibly. So to go over some brief background, cerebrovascular disease is the second leading cause of death worldwide, with a significant number of strokes in the US annually. 80% of these are ischemic, of which carotid disease is responsible for probably about 2/3. So an estimate from 2009 suggested that about 140,000 carotid operations were performed, and that number has remained relatively stable up until most recently. So to go over some of the basic anatomy, this is a study essentially of the carotid bifurcation. It's usually located between C3 and C4. There was a Japanese study looking at patients essentially with CT scan and anatomic information, demonstrating this might be slightly higher in the middle of C3 as compared to European patients where this might be slightly lower between C3 and C4. Interestingly, there were some sex differences, with women exhibiting slightly higher carotid bifurcations in men. The bifurcation level from C5 through C2 is as follows, with the majority of patients at C4. But you can see at the level of C2, there's approximately 10% of patients that exhibit a bifurcation relatively high. Now, personally, the vertebral level for me is less important when performing these operations and making the decision to operate or to perform a stenting procedure, in that the angle of the mandible tends to be more the limiting feature in my practice. So for the boards, generally, if you are to answer this question of how to gain acceptable distal carotid exposure, there are four sort of answers that I would go through. The first is obviously nasotracheal intubation. This gains you about 1 centimeter of additional space as the mouth isn't stented open, and it's easier to mobilize up by the angle of the mandible. Division of the posterior belly of digastric is an often discussed maneuver. Subluxation, not dislocation, of the mandible, and in extreme circumstances, resection of the styloid process. There are other more aggressive maneuvers that can be performed with the help of a skull-based surgeon or a neurosurgeon, but really those are more esoteric. So we'll look over some of the anatomy involved in one of the most common ways of gaining distal exposure, which is division of the posterior belly of digastric. So the arterial anatomy most commonly involves the external carotid artery branches, as we all are very aware. And the internal carotid artery generally does not carry any extracranial branches. Now, in terms of the hypoglossal nerve, we often see this tethered. And you can see in this graphic that the sternocleidomastoid branch of the occipital artery often slings the hypoglossal nerve and keeps this low. In these cases, this can be transected to essentially mobilize the nerve, and this is one of the maneuvers we'll talk about slightly later on. Interestingly, there are extracranial branches of the internal carotid artery. I encounter them not infrequently, and they're usually from the bifurcation. It's often termed the ascending pharyngeal artery. It can be obviously divided without any significant limitations in my experience. In terms of the nervous anatomy, most commonly the vagus nerve is posterior in the sheath, with the hypoglossal overlying the mid-external carotid artery. A very important point of this is that excessive mobilization of the external carotid artery is probably not warranted and may be associated with injury to the hypoglossal nerve. Therefore, it's recommended to stay relatively close, at least in my practice, to the bifurcation and just dissect what is needed. The ansa cervicalis surrounds the carotid artery, and you can see here, and these branches can be either spared or ligated as the anatomy dictates. In terms of variants, this is often encountered in an anteriorly located vagus nerve, and obviously this can be damaged during entry to the sheath. The recommendation typically is to stay on the common carotid artery on the anterior surface in order to avoid this aberrant anatomy until the position of the vagus nerve is located. You can see here the common carotid artery, anteriorly located vagus nerve, and an internal jugular vein. In these cases, I don't recommend neurolysis or slinging the vagus nerve with a vessel loop. Typically, just avoiding them and knowledge of where this is probably the best practice. This is an interesting variant seen in probably less than 1% of cases. It's a non-recurrent laryngeal nerve, usually associated with an aberrant right subclavian artery, and is more oftenly encountered on the right side, as is more common in general with a non-recurrent laryngeal nerve. Here in the graphic, you can see represented by the yellow arrow is this non-recurrent laryngeal nerve. You can see the common carotid artery here. In these cases, decisions need to be made intraoperatively about whether or not to proceed with the operation. So in terms of distal exposure techniques, I think the most important and perhaps often misunderstood is incision placement. The next few steps that we go through will give you some very practical guides on how to get to the distal carotid, many of which are very simple and do not require aggressive maneuvers. So the proper placement of the incision, you don't want to really be too close to the mandible. As you can see in this picture here, the parotid gland lies essentially by the tragus of the ear and by the angle of the mandible. In addition, the submandibular gland is also sort of in the surgical zone. In patients who have hypertrophy of the parotid gland due to, for example, conditions where vomiting has occurred, this can really be a significant cause of injury if one gets too close to the angle of the jaw. I recommend locating the incision away from the angle of the jaw, and in fact, this incision in my practice is a little bit too close to the angle of the jaw for comfort. In addition, you can see here in this circled area where the angle of the jaw and your distal endpoint are going to coalesce. There's often a large clump of lymph nodes in this region as well, and these all need to be mobilized. So I think the ideal incision actually takes a sort of a jog off towards posterior to the angle of the mandible and posterior to the tragus. And this really allows you to get access to the internal carotid artery, which is slightly deeper located. Nerve mobilization. In terms of the hypoglossal nerve, this is one of the common reasons that people find difficulty in completing a carotid operation. So a low-lying hypoglossal nerve, as you can see here, overlying the bifurcation here. Really the main thing to do is first look for the obvious arterial tethers. Once again, we spoke about that occipital artery with the sternocleidomastoid branch, and that can be divided to allow you to perform a complete neurolysis. Then you can decide if you need to work above or below the hypoglossal nerve itself. In this case, you can see a beautiful example here of where there's an arterial tether, and this hypoglossal nerve could clearly be mobilized, allowing you access to the distal internal carotid artery. So working above and below the nerve. Typically, you're really going to just need to place your clamp at the distal, above the distal endpoint, and your end arteriectomy essentially mostly can be completed below cranial nerve 12. So if you create a space distal to the nerve, essentially in this space here, and work along these motor fibers of the vagus nerve, sweeping them away, you can clear yourself a small amount of room for the clamp and allow you to safely perform the end arteriectomy below the nerve. This usually does involve ligating or dividing the digastric muscle, and that's usually of no consequence. So this is an operation from earlier in my career where I found this low-lying hypoglossal nerve, and you can see that we're right up the angle of the jaw here, and already things are becoming difficult. So skeletonizing the bifurcation and the common carotid artery really gives you some more access to this region. And in addition, once you have clamps and you've heparinized the patient, traction on the bifurcation really gets you much more mobilization than you could have imagined. Other maneuvers that can be utilized involve collaborating with ENT colleagues or skull-based surgeons who have experience in this region. Subluxing the mandible here allows you to essentially gain about 1 centimeter here of additional space. And once you've divided the posterior belly of digastric, the distal internal carotid artery is much more accessible. Here you can see in this manner, you really have a large amount of exposure here, and this should allow the operation to proceed without undue concern. This is a much more aggressive approach. This is where one comes anterior to the tragus and obviously requires, again, ENT collaboration because we're not often in this region. One needs to be concerned about the parotid gland and have the colleagues mobilize this superiormedially so that the posterior belly of digastric is available. Once this has been divided, then this really gives you excellent access to the distal internal carotid artery, and now the operation can proceed. In summary, the angle of the mandible is my personal nemesis, and really this is more important for me in terms of distal exposure. Fully mobilizing the carotid can allow you sometimes to pull down on the bifurcation and actually gain additional length on the internal carotid artery, especially if this is mobilized in a 360-degree fashion. Oftentimes there's some redundancy in older patients, and this will allow you to pull down on the internal carotid artery to gain exposure of the soft portion for a clamp, and then this makes the operation much more feasible. Taking the digastric muscle, the posterior belly up, should be done routinely if you're having trouble, and then consider a neurolysis to the hypoglossal nerve, and even considering coming above and below the hypoglossal nerve itself to perform the operation. Finally, you should never forget about alternative strategies in these cases. There are options to close the patient and observe, especially if asymptomatic. Rather than doing something risky and something you've not done before, consider nasotracheal intubation, or collaborate with a colleague or with an ears, nose, and throat specialist or skull-based surgeon to allow you some additional mobilization. Finally, transcarotid artery revascularization and transfemoral artery stenting are all options that can be considered in the patient where this is truly hostile in terms of the anatomy. Thank you very much.